Just hi, we have Dr. Mark Braunstein joining us today for this exciting episode. And he has an incredible history of owning and starting companies. He has a medical degree and background, of course, in teaching at Georgia Tech, as well as at the University in Australia. So I want you to tell the audience about yourself because your background is quite impressive.
Well, I don't know how impressive it is. It's long given my age, but thank you for having me here today.
Absolutely.
I started out going to MIT and getting interested in computers long before you could even major in that, and got the idea of combining a medical degree with my interest in computers. And that led to developing one of the first ambulatory electronic medical record systems. That's for use in a clinic, not inside the hospital. And that actually led to starting the first of a couple of startup companies, which got acquired. And I moved to Atlanta. And after the second company was acquired, I joined Georgia Tech, where I taught for 15 years. I'm now an emeritus professor, quote, retired, but I still teach at the University of Queensland in Australia and work on various things at the Australian eHealth Research Center, which is their national lab for digital health.
Yeah, you've recently actually went back there and came back about a week and a half ago, which is awesome to have you back on. And tell us a little bit more about the research you're doing there, and some of the things you're working on today.
Well, like everybody, I've gotten interested in artificial intelligence. And for many years, I was teaching and working using something called FHIR, FHIR, which is, I won't go into the details, but it's a standard for representing health information so it can be shared among the various systems that, for example, a patient may see multiple doctors, even in different hospitals. And the idea is to be able to bring all that data together digitally. And actually, if anyone listening has an iPhone, you can do that with the iPhone. It's using FHIR to get your records from wherever your health is delivered, and it puts it all in one nice package for you. Anyway, I'm involved in various projects around the use of FHIR, and I'm teaching at the University of Queensland a course where students develop apps under the mentorship of an expert, a physician or a researcher or at our lab to solve a problem, developing an app that can actually be connected to an electronic health record system. And of course, now focus is turned to artificial intelligence. Last year in the course, some of the students actually worked on apps that used artificial intelligence for various purposes.
What
And
are some of the purposes? I'm just interested. What are the things that students are seeing benefits from? What kind of applications?
well, it's really their mentors, but yeah, well, the group of students that I managed was working on a project suggested actually by one of the physicians located in the hospital where our lab is housed, and it connected to a AI API from a company in Boston called Gen Health,
Okay.
and they they packaged up they got the data for the patient in the FHIR format, and they packaged it up in a special version of that that the company specifies. And the model came back and suggested how that patient should be cared for in the future to get the best clinical results. And that was all presented to the physician within the context of an EHR. Actually, we're using a simulated EHR. The physician just clicks a button, the current patient's data gets sent to the model, and the physician gets some advice on how they might want to care for that patient. Um,
That's pretty
another
incredible.
another very interesting project is, even though we think everything's digital, it necessarily isn't. And at least at this hospital, many patients get referred for specialized treatment and care, and the general practitioner out in the community often sends a scan or a fax of their records so the physician knows about the patient. Well, these can be hard to read, lengthy. And the idea was, can we use AI to read the handwriting, turn it into text, and summarize it
Mm.
for the physician? And we got some reasonable results. And now we're working with a more advanced, or going to be working with a more advanced AI model that, at least in our testing, gives actually quite good results. So the message here is there are a lot of practical things that AI can do in healthcare. And I guess the question is, should people be concerned about things like hallucinations and
Right,
bias?
that's what I was thinking.
Um,
Accuracy. Yeah.
and there, I argue that healthcare is actually quite different than other fields. Over the decades, actually starting in the, the 80s, really. No, excuse me, the 70s, really. People have been thinking about working on how you might standardize the way healthcare data is represented. And today, those standards, they go by names like SNOMED, which is the international standard, or the International Classification of Diseases, which is used here in the United States and around the world, but it's central to billing here. And they provide a standardized way of representing whatever is going on with the patient. So, can you use these standards to train the model rather than training the model on the internet where it's going to be exposed to all kinds of strange stuff?
Mm.
And the answer is increasingly yes.
Okay.
And this model that my students worked with on their project was trained on the records of millions of patients, their claims and their medical records, but only the structured part, stuff that's represented in standards, which makes things pretty unambiguous and largely gets around the issue of hallucinations. Um,
Yeah.
there are other ways these things can be applied. The company that has developed a tool that can read the handwriting and turn it into text and summarize the chart uses SNOMED, the model I mentioned earlier, to validate that anything that the AI model puts in the summary is actually in the patient's chart. It isn't something it just made up.
Oh, that's great.
Yeah,
That's
and
a
that
great.
seems to be working quite well. So I think patients and physicians who are watching this podcast should feel like there's real progress being made in not only developing the AI models, which of course we can do, but using the tools we have available to us, particularly in healthcare, to make them more accurate and avoid they're just making stuff up.
Do you see a risk of doctors kind of over relying on this technology instead of kind of doing that physical exam, ensuring that they're actually following kind of the proper procedure instead relying on AI to make their decisions for them?
Well, actually, I'm going to turn that around. The concern that a lot of people have is patients over relying on these models. Of course,
Mm.
patients are exposed to the large language models like ChatGPT, which weren't trained the way I'm talking about. And will they use them instead of going to the doctor for advice and maybe be even led to an improper treatment? So that's the concern people have. Actually, I think the issue with doctors is, are they going to be willing to rely on these models? I
Mm.
think they're definitely going to be willing to rely on them for things like the summarization example I just gave you, because
Right.
doctors spend a lot of time reading and summarizing patient's care. For example, when the patient is discharged and sent home, they have to summarize what went on in the hospital. If they're a doctor out in practice and they refer a patient to another doctor for some specialized region, they have to do the same thing, and that's very time consuming. And I can tell you, doctors really don't like to do it. Nurses spend maybe a third of their time on administrative functionality, a lot of which I think these AI models can do. And in fact, we're increasingly focusing on nursing in some of the work we're doing. So,
Especially with voice to text, right? Like multimodal, it might make it easier because they can just speak whatever is happening with the patients and then it can be transcribed.
yeah, well, and also, well, that's actually leads to some interesting thing called ambient dictation, which is happening a lot. There are a number of companies that offer it. And the idea is the doctor, while they're in the room talking to the patient, uh, maybe has their phone turned on, and it records the conversation. And the AI model summarizes it and turns it into text and creates the note, which the doctor has to look at and approve, and they can make whatever edits are necessary. There are likely going to be some because speech recognition isn't perfect, but it potentially is a big time saver for doctors who spend an enormous amount of time
Yeah.
doing charting, far more in the United States than in most other countries because we have such a complicated healthcare system and healthcare payment system. And there's all kinds of documentation requirements placed on physicians that at least some of which I think AI could do for them. And I think that would be very popular.
We're even providing those customized templates for each doctor, right? Like based on those requirements you described, that will actually gather that information from that interaction with the patient and put it into the specific format that the doctor likes to keep his notes in, for
Well, and
example.
these models, these dictation models actually learn each physician's style of medicine and practice.
Okay.
And they can adjust for the fact that this is a cardiologist versus a pulmonary doctor versus a general physician. So all that sort of stuff is being done.
That's very impressive. What do you, as you look into the future, right? It's always exciting. I mean, things are being updated. How do you see the scaling across the medical field? Do you see it being adopted by the larger medical community? Who is going to lead the charge?
Well, this is healthcare. It's never obvious. Um, hospitals are starting to take this very seriously. I would predict that the initial adoption is going to be largely focused on practical, time saving things, like some of which I've mentioned,
Mhm.
making dictation more efficient, doing chart summaries, that sort of thing. But over time, I think we're going to see this used more and more in clinical practice. And I mentioned Gen Health earlier. I think their model, which they call a large medical model because it's trained only on medical data, suggests some many dozens of things that could be done to help physicians in practice to not only suggest future treatments, but identify patients in their practice who are heading into trouble and
Mm.
need to be focused on. And of course, these days, physicians are often paid based on their ability to produce superior patient outcomes at a lower cost. I think these tools can be very valuable in helping them do that. So they're going to be used quite broadly, but as I've suggested, they're going to have to be properly designed for healthcare. And there's not going to be any real tolerance for errors and hallucinations and bias and that sort of thing. And based on what I've seen so far, I'm somewhat optimistic that by combining these health standards, including fire, with AI, we can produce tools that are finely honed. The term is fine tuned to the needs of healthcare and get the kind of results that we all want to see.
That would be amazing. And one of the examples we kind of talked about before was personalized medicine. And you showed kind of the Gen Health data in practice, how you could, based on patient records, predict what the impact will be on a certain population. Do you want to talk a little bit about how that, these large language models specific to medicine can be used to personalize medicine for patients?
Well, so what we'd like to do is treat each patient as an individual based on their specific clinical, genomic, socio-demographic, and other factors. Now, the reality is that's too much data for a physician to process in the amount of time they have to care for patients. So, we're going to see, I think, models bringing all this data together. You mentioned multimodal, and people are unsurprisingly working very hard on how you bring genomic data into these models. And I can see the day in the not terribly distant future where the model will at least help the physician process all of that diverse data and sort of put each patient in the proper niche, the proper
Mhm.
box, the proper category. So their treatment then potentially aided by the model, which can suggest what, based on the data it has about millions and millions of patients, are all the patients that the Emory Health System has ever seen, or whatever it is, suggests the treatment that's most likely to be effective for this particular kind of patient.
Yeah, which to me is huge, right? Because I think doctors kind of prefer certain medicine or they've seen studies that work. And so, but those are more generic, right? Versus specific to that
Well,
individual.
and of course, this is already happening to some degree in cancer treatment. I mean, today we have very interesting new cancer medicines, particularly immunotherapeutically based medicines that are going to work in a subset of patients based on their genomic and other factors. And we know aren't likely to work in patients who lack those factors. So people are starting to do that sort of thing in cancer, but I'm really saying it's probably going to be done much more broadly.
That would be
And
incredible.
it's important to consider socio-demographic factors too, a patient's education, where and how they live, their economic circumstances and means, all have an impact. There was an interesting study done a number of years ago that showed that children, generally poor children, who live near an expressway have much worse problems with asthma than children who don't live near an expressway. So all of this stuff needs to be taken into account. And a model can not only be trained on all these patient records, it can, of course, be trained on the medical literature and can combine the two. I think we're heading down this road. It's just important that it be done properly, that uh, people respect healthcare and the differences between healthcare and other fields, and that this just doesn't get out there in a noisy way that patients can be confused or misled and that sort of thing. That's going to be hard.
That is going to be hard. I foresee kind of a group of AI verify agents, and for lack of a more elegant term, but we need agents that, or AI that actually checks the other AI results, right? Randomly and make sure that there is actually some input there, that it actually makes sense. You can't just, we have to kind of build an ecosystem around these agents that are going to be helping in the medical field or somewhere else.
Well, that's actually already starting to happen.
Okay.
You've got really good instincts. There's a company on the West Coast called Curai, Curai,
Okay.
who was actually founded by the son of one of the big venture capitalists on the West Coast, and he's determined to fix healthcare with technology. And broadly, he's thinking about the globe. And of
Oh,
course,
that's
there are
awesome.
lots of situations around the globe where traditional healthcare isn't available and is unlikely to be available. So he's thinking that AI might be a tool for that. And he's doing exactly what you suggested. He's got two models that converse and interact with each other
Hmm.
to improve the accuracy of the results. And there are other people doing the same sort of thing. In fact, I've heard it said that these models may be better at correcting each other than they are at the initial output. But there's certainly suggestions that's going to work.
And that makes sense because AI is all about pattern recognition, right? So I can see how, the response, if it's following a specific pattern, a system could check that pattern, whether it matches that pattern or not. It's probably harder for humans kind of to do that. But from a verified perspective, it's probably easier just based on how AI operates.
Yes, the subject of patterns is interesting. I don't know if and many people listening to this have ever heard the term embedding, but if you've ever thought about what does it mean to train an AI model? So the models look at an enormous amount of data. We all know that. And they identify, as you've suggested, patterns in that data and
Right.
relationships in that data. And those get expressed as a series of numbers that are attached to each word or parts of words. The term is tokens. It's a unit of information that the model works with. And each token is embedded with a long series of numbers. It may be hundreds of numbers. And we don't know what those numbers mean. That's another issue with this. It's a bit of a black box.
Hmm.
But they're where the meaning and the relationships are stored. And the model uses that to understand what we're asking it for and to match its embedding with the embeddings of all the information stored away in its gazillions of bytes of memory, and it finds the relevant information, and that's what produces the output.
Interesting. Yeah, that makes a lot of sense. Right, to me, that's the scary part, right? What you mentioned is like it's a numbers, and we don't know exactly what the numbers mean. So, from a human machine oversight perspective, right? Machines maybe can oversee machines better than humans overseeing machines, just for that reason.
So the guy on the left is one of my colleagues in Australia, John Grimes. And I mentioned SNOMED, which is far and away the most comprehensive standard for representing medical concepts. And as you can see in yellow up there, there are over 350,000 concepts in SNOMED. And SNOMED doesn't just represent the concepts, it actually represents the relationships among those concepts, over 1 million of those. So John has done what I just described. He's created an embedding of SNOMED, and all those zillions of colorful dots in the middle think of them as the tip of an arrow, a vector. A vector
Mhm.
is an arrow, a number that has direction. And now the actual embedding is many, many numbers. And here it's reduced to 3 dimensions, and there are tools for doing that. So you can graph it this way. And if you understood what I said, you would expect that there are relationships and meaning attached to these dots. So actually, the tool I just showed you is interactive. You can zoom in on it. And I zoomed in till I found what I was looking for, which was a isolated area, separate and apart from anything around it, that had an interesting shape. And that big blob in the middle, uh, and that arm going off
Mhm.
at about 11 o'clock. That's a bit separated if you look carefully from the blob. And when I looked at all the dots in the big blob, they're drug allergies. But over there in the arm, they're food allergies. Now, obviously, they're allergies, so they're closely related to each other, and that's what you'd expect because the embeddings are very similar. But the model has taken advantage of the wisdom that's in SNOMED, and it can now distinguish a food allergy from a drug allergy. So this is a very simple example of what um, embeddings can do for us. I've mentioned Gen Health several times, and here's an example of their embeddings. It's actually on their website. You can go find it and look at it. And it's all coded data. You can see on the left are the 6 different coding systems they use, and each is assigned a different colored dot. And the dark green dot is an ICD code for malignant neoplasm or tumor of the thyroid gland. And it identifies relationships among and between those concepts, and they're represented as white lines on this diagram. And there in the lower right, I found one that I thought was interesting just from where it was positioned. And it's a CPT code that's used in billing in the United States. So for a doctor to get or hospital to get paid, they have to give the insurance company the ICD code, what's wrong with the patient, and the CPT code, what did I do to diagnose or treat the patient. And this is a pretty obscure code. I'd never heard of it. Something called ERG. And
Hmm.
did some research, and it's actually a relatively new finding just a few years ago of a gene that is apparently a signature for predicting the occurrence and progression of this kind of cancer, thyroid cancer. So the model has figured out that this test relates to this kind of a cancer. So you've seen here, I hope, that these models figure stuff out.
Yeah, I think that's super fascinating.
And that's what's going
I
on. That's why we're seeing such amazing results when we go to ChatGPT. Now, before I wrap up, the key here is SNOMED is accurate. It's been developed over decades by experts in the field. Um,
specialized model for medicine only, not
but
just
it's
intermediate.
very, very sophisticated model. So you train a model on it. You embed SNOMED for the model. It's not going to pick up inaccuracies or biases or hallucinations. Still up to the
Is it an
model.
open or closed model? Can anyone build on this model? Like, what is the?
It's freely publicly available.
Okay, perfect.
So is ICD. That's not true of CPT. CPT is owned and managed by the American Medical Association. There is a license fee, but it isn't onerous.
And that's what can allow all this innovation to happen because if someone can build on top of SNOMED, for example, they already have a great corpus of data to start with, and then they can
Oh, it would
essentially.
be an unbelievable effort to recreate SNOMED. Now, I suppose it's an interesting question. Could a model do it? And
Hmm.
there's probably some researcher out there exploring that right now, but I haven't run across that.
Huh. That's super interesting. Well, thank you so much. It's super fascinating. I know I have a community of doctors I talk to every day, and I actually talk to them about this research, and they were fascinated. To your point, they have 15 minutes with the patient. How can they provide this value that the model can kind of advise them on, in addition to their expertise, of course? And
Well, I hope I haven't scared anyone, but my goal is to make people a bit more comfortable with this technology when it's properly developed and properly
right.
utilized.
Well, thank you so much. Thank you so much, Dr. Braunstein. This was amazing. Thank you for doing this recording. I do really appreciate it. I think it's super valuable.
Okay,
Have a
well,
wonderful day.
thank you, and you have a wonderful day as well, and a great week.
Thank you.